in Oklahoma State. And one of our favorite things to do is to make people better in regard to their pain and functional capabilities, one person at a time. And one of the things that we like to do is treat things that are fairly common. We treat the arcane and esoteric, sure, but the common things are very important, because if, when I started off in residency, Elliot Zerhouni, who later became the chief of the NIH, which you probably recognize the name from that, he said, if you want to really make a difference, research things that are common and make a difference in things that are common, and you'll make a huge impact. And I would have to say that is absolutely true. And so one of the things that we've done is we've tried to expand the offerings for something as pedestrian and garden varieties, osteoarthritis of the knee. So pain from that is really related to the degree of arthritis. It's related to the degree of that the patient is affected. And osteoarthritis of the knee relates specifically to the increasing age and weight of the people that are affected by it. And so I don't know about increasing age, but our age expectancy, life expectancy has gone up to right around 80. And that was age 40 was life expectancy at the turn of the 18th to 19th century. And it's really gone up profoundly since then. I don't know about you guys, but I don't see any decreasing in weight despite the GLP-1 agonist. Maybe that'll move the needle, but it seems to be the increasing size of the population contributes to that. And I'm going to share my screen, as I would like to show you some of the things that we've worked on, and to try to let you know some of the new techniques. And this talk is entitled Next Level Genicular RFA, and that really is what I want to try to make this. I want to try to show you hopefully a glimpse into what the next level is. And this is directly lifted from Zach McCormick's article about the anatomic innervation of the knee. And I saw this and I thought, this is a great template. There's degrees of variation. Fontu and Chen and a number of other authors have listed the degree of variation. Jameson, there's a good article by Tran, and there's a lot of variability of this in combination with a lot of nerves that we just don't typically ablate. We don't typically ablate on the lateral side, but there is an inferior lateral genicular nerve as well as a recurrent fibular nerve. We don't currently ablate the posterior portion laterally, and there's a terminal articular branch of the common fibular nerve there, and including the infrapatellar branch of the saphenous nerve, the one superior and medial on the tibia. And these are really important nerves, and especially the last one that I mentioned, the named nerve. This is one that really can cause significant debilitation and significant pain in the nerve. And so the genicular RF started off as a 3 ablation zone radiofrequency ablation. So Kikuchi and Choi did this back in 2011. They carried it out to 3 months, found statistically significant improvement out to 3 months with a response rate of about 60%. So about 60% had their knee pain cut in half or more, and importantly, they didn't have any significant adverse events. And so Tim Davis, this is one of the salient early papers in 2018 compared genicular RFA using cooled radiofrequency, CRFA, with steroid injections of the knee, and importantly got statistically significant pain function and quality of life improvements, and got improvements. I'll show you some of the degree of improvements here in a second, but it was statistically significant, better than intra-articular injections, with the response rate of 74%. Now, that's pretty decent. So almost 3/4 of the patients were able to have their pain cut in half or better with a really prominent statistical p-value. And so pain function quality of life, so the PGIC, perceived global impression of change, and this is a rating by the patient, was at 91%, and numerical rating score reduction was 4.9. So just kind of lodge those values in your mind just for a second. And this was all the way out through 6 months in this study. This study was later carried out to 2 years. One of the things I really want to point out, though, despite these really good results, there was 25.9%, almost 26% of these patients were non-responders, almost 26%. Move forward to the VISCO trial by Chen, and I was part of this trial as well, out to a year, and then with a care and follow-up out to 2 years, and the results are excellent. They're about the same as the Davis trial. And so up to 4.4 reduction as compared with 4.9 in the first trial I mentioned. And then the PGIC up to about 75% as compared with 91%. So these are in the ballpark, and the pain, function, quality of life were all statistically significant throughout all points, all the way out, importantly, to 2 years. And so I graphed the first year for both the Davis trial and the Chin trial. So the intra-articular steroid trial compared to large volume, which at the time was only relegated to CRFA or cool RFA. And so these results are almost identical in terms of pain reduction. And it goes almost superimposed, almost able to be overlapped. And so you compare this with standard RF, I mean, Santana, Sari, Choi, et cetera. There's lots of standard RF, and that's kind of all over the board. Very variable, highly variable as compared with almost superimposed curves that overlap for, this is the pain curve, but the PGIC curve, almost everything else overlaps, very consistent results. So why is that? Well, Leo Capel did a trial with 170 people in each group. One was traditional RFA, the other one was large volume RFA. And the conclusion of that is not only the magnitude of pain relief, but the duration of pain relief was greater after a large volume ablation. And this really should be no surprise. I just mentioned there's a high degree of variability of this, and the large volume is able to ablate a larger volume of tissue. And the large volume is defined, I usually tell people it's about 600 cubic millimeters. And so how does this compare? Standard RF is about 170 cubic millimeters, and it's cylindrical shaped. The protruded RF, protruded tine RF, is about 215. It can go even up to 300. So this is the Stryker Venom. And the large volume is right around 600. So traditionally it had been cool RF. Now we've expanded this up to multi-tined RF, and the ablation zone is more elliptical in the cool and more ellipsoid, kind of like shaped a little bit like a Hershey's Kiss in the multi-tined RF ablation. So here's an example of that. On the left, you get the cylindrical, then the widened cylindrical, and then the cool RF is elliptical, and the ellipsoid with the expanded multi-tine with the Stratus Nimbus needle, as we can see there. So
it's the last 2 weeks we're trying to how to do this. Your admin person, Diana, was very helpful.
Oh, thanks for letting me know. Well, the next
large volume ablation zone. His response rate I mentioned in the Davis trial was 25.9%. So the Chen Visico trial, the non-responder rate was 29%. So I don't know about you guys, but I don't like non-responder rates to rise up to the point where about 1 in 3 patients are non-responders. And so as good as it is, and as much as I started off doing 3 ablation zone technique, I quickly switched to the 4 ablation zone. And then we kept on with and had results of about the same. We have about a 75% responder rate, about 25% non-responder rate, and it lasted out throughout 2 years. But this is so common, and we do so much of these, we're having the non-responders pile up. And so that was something that really bothered me, and I started looking around for a better technique. And so there's several anatomic studies, as I mentioned, that have the variability of the nerve. I mean, Jamison Tran and Funko. And there's also additional studies that show there are about 10 transmission nerves that transmit pain that can be amenable to RFA, 10 of them. And then there's the Chan and Funko study that show that the more nerves you ablate, it's directly related to the success of your outcomes. The more nerves that get ablated, the greater the degree of success. And so back to Zach McCormick's diagram that was published a few years ago here. So I'm going to show you the ablations that we've come up with. So this is designed for economy of scale. There's 4 ablations with 13 points of 90 seconds each for a total of 360 seconds. So this is 6 minutes of burn time. As compared with Cool RF, it's a 2-minute 30-second burn with a 15-second ramp, so 2-minute 45 together. And so we get some of the nerves that you'll see. We get all along the distal femur. We will get the superior and lateral genicular. We will get nerves to the vastus medialis, the lateralis, the medial and lateral branches of the vastus intermedius, the terminal articular branch of the common fibular nerve, and we will start distally and pull it back proximally. We go to, and this is an example of the proximal pull. In addition to starting distally and pulling proximally, we will start distally and pull proximally for the suprapatellar portion or the subpatellar plexus. And this is an example of lateral nerves that get ablated in terms of the recurrent fibular nerve and the inferior lateral branch of the genicular nerve, inferior lateral genicular nerve. One of the comments I've heard about this is, aren't you afraid of getting the common perineal nerve? And to refresh everybody's anatomic knowledge, the common perineal nerve wraps around the metaphysis right over the nadir of the metaphyseal flare of the fibula, proximal fibula. And so we're not even close. I mean, that's 2.5, 3 centimeters away, even from the recurrent fibular nerve burn. So if you hit the common perineal nerve, we can't be friends anymore because you're not even in the same zip code, and that's way far away. And here's an example of the subpatellar plexus and taking the nerve supply away all the way from distal to proximal. So the burns on the distal femur are distal to proximal, and you have 2 lateral and 2 medial on the proximal tibia. So here's an example to contrast. Here's the 3-point technique, 3 ablation technique. Here's the 4 ablation technique, the subpatellar plexus added in. And here are the AP lateral branches of the 13-point technique. And so you can see that this is a carpet bombing technique, and that's actually what we just colloquially call it just by name. This is a wide zone ablation, or the carpet bombing technique of the genicular RFA. And we've done this up to now. We're collecting data, and we've done this on the grand total of about 250 patients with far less data collection than that. But this is one of these things that was originally a proof of concept, followed by the data collection. So genicular RFA is safe and effective. We've known that from the very beginning, all the way from 2011 onwards, for a really common problem of painful osteoarthritis of the knee. And I think it can be improved by using a larger ablation zone and ablating additional sensory nerves. What is the number of ablation zones? I mean, is it 7? Is it 10? Is it 13? I've given you an example of how you can ablate 13 ablation zones in a total of 6 minutes total burn time. And the bottom line is genicular RFA is not only very good and provides good pain and functional improvement, but I think it can and should be improved with the larger ablation volume and more nerves being ablated. So improving the genicular RFA is our next immediate goal. And with that, I'll stop right there and open it up for discussions, questions, comments, etc. And thank you for your attention.
Great presentation, Doug. Hi there. So in terms of time of ablation, have you seen a difference basically? Because I do them with 4 ablation site or results. As you mentioned, there's some patients that just simply do not respond, and it just does not make sense. So I mean, what you're presenting is awesome. The other factor that I always question was the ablation time. So do you have any data on that you've seen, or like what's your thought on that?
So our response rate, I don't have any data published, and so I just will caution you that this is non-published, and this is just provisional type of stuff. And provisional data is close to your non-randomized, non-placebo controlled study of your own opinion. It's close to that. But in regard to the ablation time, so we do 90 seconds times 4 for 360 seconds. And of course, you have to move the needles, but what we found is we place the needles deep on the femur and pull it back, so that saves time and needle placement. And in the fibula, you have to have placements medial and lateral, so 2 points each. And the total procedure time is about 20 minutes. So the burn time is 6 minutes. The total procedure time is about 20. And, you know, I started off with Cool RF. As you know, Olivier, we started off with Cool RF. And so with the 2 minute, 45 minute, 15-second ramp and 2:30 burn time, it's not much slower than that. I mean, that's about the same as 2 burns with Cool RF using 4 time points. And, you know, as I like to say, if 2 or 3 minutes are worth it to you to make that patient better, then I think that is something I agree with it completely. We've gone from about a 25% non-responder rate to less than 5%. And I don't really have an idea about what it is less than 5% in terms of the exact number, but it is less than that. And the people that tend to fail are in 2 different categories. They tend to be complex or revision arthroplasties, and they tend to be patients that have a very high BMI with super severe arthritis.
Super, thanks.
You bet.
And I see that Dr. Jacobs is asking if you always use fluoroscopy over US. We've had great improvement with 4-zone techniques using the US. Thank you, and very interesting.
Yeah, so we use fluoro. I like ultrasound because as Dr. Jacobs knows, it's a neurovascular bundle, and the superior and inferior genicular nerves, both medially and laterally, run along with the artery, the genicular arteries. And also, as you probably knows, these arteries and the location tend to be very variable. So that's one of the secrets about sauces about the large ablation volume, is that the larger the volume, the more greater the chance you're likely to hit the nerve. And for anybody that's done vascular work, you know, as an IR, I used to do vascular work a long time ago, and we do aortograms and long leg runoffs, and you would see, you know, pretty decent variability of that artery, the genicular artery. So it's no surprise that these nerves are going to be variable along with that. So, and the real key about ultrasound is you can see it. You have a target, a surrogate target, albeit surrogate targets. You can't actually see the genicular nerve. You can sometimes, but most of the time you just see the artery, and you know the neurovascular bundle's right there. The downside about ultrasound is a lot of times, like the subpatellar plexus and some of the inferior lateral genicular, inferior patellar branch of the saphenous, the terminal articular branch of the common fibula. You don't have a marker for that. There's no vessel next to it. So if for the extended ablation, the large number ablation, it's I think fluoro is about the only way that you can do that and aim it accurately.
Next question is, any tips on how much local anesthesia you are using for the needle placement? My recent patients have been having a lot of pain with just patient. Also, thoughts on indication for younger patients with refractory patellofemoral pain. I'm getting consults from ortho to consider this, but I'm hesitant for these 20 to 30-year-olds on needle placement.
Yeah, so I'll take the last first. So for patellofemoral pain, why not? I mean, why be concerned? Why be resistant? Why hesitate? Why? Because for patellofemoral pain, this is a problem. I mean, you can do a lateral release, and if the lateral release doesn't work for patellofemoral chondromalacia, you can do tibial tubercle osteotomy and transfer. Now that's real surgery, not to mention a femoral trochleoplasty, where you kind of realign and deepen the femoral trochlea, and you do that for conditions like patellofemoral dysplasia, femoral trochlear dysplasia, And these are big surgeries, and there's not a lot of really good options for these patients. And I'm not talking about old, I mean, specifically, young female is the prototypical one with a big, large Q angle, and you don't want to have to do typical tubercle osteotomy and reimplantation or tibial osteotomy. So these are things that there's very few really good options. So, and I don't do those primarily for this reason. I do a few of them for patellofemoral pain. Most of them are for femoral tibial arthritis. But yeah, I mean, some of the nerves that we do, like the subpatellar plexus and some of around the infrapatellar branch of the saphenous, the recurrent fibular. I mean, these are things that do provide innervation to that part of the joint. So I would say just relax, don't worry, and and try this, because these patients have very few other options, and this is hardly invasive at all. And that kind of leads me to the second question, which was about the amount of lidocaine. I hear people kind of say genicular RF is just RFA, just like any other RFA. It's not. This is a painful procedure. Genicular RFA hurts, and I use copious amounts of local anesthetic, a lot. I mean, we did one today and this morning, and I used 1% lidocaine, and it's infiltration, but I'll use 20 to 30 cc's of lidocaine, and often I'll mix lidocaine with bupivacaine if you're worried about lidocaine toxicity. 17 cc's of 2% lidocaine, you can run you into borderline lidocaine toxicity, but you're not injecting this intravascularly. It elutes by secondary deposition because you're putting it into the soft tissue. And so I wouldn't worry about it, but if you are worried about it, mix it with bupivacaine. Lidocaine to give it a little bit of immediate action, and bupivacaine takes effect after a few minutes. But make no mistake, I mean, this is a painful procedure, and I tend to do this more under deep sedation, supine MAC with propofol, or whatever deep sedation parameters, medications you like to use. But this is something that you need to be using copious amounts of local anesthetic. You need to consider sedation that's more than moderate, for at least for some patients. And you have to understand that this is not RFA of the medial branch with the lumbar spine. This hurts quite a bit.
Okay, next one, are any risks if artery is coagulated with thermal RF of genicular nerves?
Nope, not that we've seen. So I don't know if any of you guys have heard about genicular artery embolization for osteoarthritis. You can embolize any artery. I've seen it done in the shoulder, the elbow, the first carpal metacarpal joint, the knee, the hip. So you can embolize any arteries to any joint and get pretty good results. And so that begs the question, I mean, is it really the artery, or is it really the nerve that we're ablating that causes pain relief, or is it a little bit of both? So some of the interventionalists out there that do vascular work will embolize the artery, and they get results. Sonny Baglis had a couple of papers that have really good results in clinical trial that are fairly similar to genicular RFA. But my take on that is that, number one, it's a little bit more invasive. I mean, to do a femoral arterial puncture, just to do a genicular artery ablation for osteoarthritis of the knee, that's a good technique, and it clearly works. I wouldn't start off with that. I start off with genicular RFA. And I don't know if it's really important to sort out, I mean, how much is ablation of the nerve contributing to the pain relief versus ablation of the artery that's right next to the nerve. And to a certain extent, I don't really care. I mean, as long as I'm getting good durable relief all the way out to 2 years, I think it's okay. And I think the more we ablate, the more nerves we ablate, the better it works, and the greater degree of responder rate and the greater the magnitude of pain relief. So I think this is something, and a lot of these nerves, as I mentioned, are not associated with vessels. Only a few of them are. So I think probably the way to start off with in terms of efficacy, and this is incredibly safe, that back to the original question, people purposely coagulate these arteries, and there's no adverse events, there's no osteonecrosis, there's no denervation to the point where your proprioception is off that we know about. And people, the other corollary to that is, I've been asked about Charcot joints. I mean, keep in mind, Charcot joint is not the same process. We're just denervating the pain nerves, and there's 10 pain nerves, and I'm trying to take all of those pain nerves that we know about there that can be RF'd and ablate those. Charcot joint has a problem with a metabolic problems typically associated with severe neuropathy. Usually it's things like diabetes, or syringohydromyelia for the shoulders and the cervical spine, the spinal cord. And it has to do with a vascular phenomenon about effect of the vasculature on the osseous structure. So this is a completely different thing. It's never been reported. I've never seen it. I've never heard about it. I've never heard of coagulating arteries causing any type of permanent damage, muscle necrosis, osseous necrosis. That's never been reported as far as I know. So I think although there might be a theoretical concern, I don't subscribe to that theory, nor do I know that it has ever existed or been reported.
Okay. What needle approach do you take toward the subpatellar plexus, AP or lateral?
So I go lateral. I start on the lateral side because there's less muscle there, and the vastus medialis obliquus comes down farther on the medial side. So I go on the lateral side. I go in the position that I showed you, and it's lateral to medial, and then I drag it back. It's distal to proximal, right on top of the bone, and you just ablate all the way across, and it gets all of those nerves in the front, the nerves to the vastus medialis lateralis and the medial lateral branch of the intermedius, along with the subpatellar plexus. It provides a good adjunct to all of those. So that's how I do that.
Do you offer any antibiotic prophylaxis in patients who had knee replacements and having ablation?
Yeah, I do. Just like I don't know if that's necessary, but I think if they can get it at the dentist, they can get it with me too. And the thing about totally arthroplasty is, it's antibiotics just makes me feel better. A lot of the infections we're seeing with arthroplasties in general have to do with C. acnes, P. acnes, and kind of indolent things like this that will not be staph or strep and be really angry and have a lot of bony resorption that will just be persistent pain. So, I have a low threshold to give antibiotics, and we give antibiotics for everybody that we do RF of a joint that has had a prior arthroplasty.
Any nimbus large lesion hesitancy with shallow target sites, blended needle lesion sizes?
Okay, so I'm not sure I understood that one. Tammy, what was it?
I guess just the hesitancy of shallow target sites with large volume
Oh,
lesion.
yeah. Yeah, for sure. I mean, you have to be careful with that. I've seen one case of skin necrosis over the top of an ablation. That was with the tumor, it wasn't with the genicular RF. But especially in places like the proximal tibia, medially, the shin bone, you have to be careful about that. And you can inject a tumoral amount of infiltration of lidocaine just to kind of raise the skin up, and it makes you feel better. You can put a glove filled with cold water over the surface of the skin. That's something we do and have done for RFA of different, and not necessarily the knee. I guess I've never really had to do that with the knee, but if it makes you feel better, you can use that because it's been done over the dorsum of the hand, the fingers, superficial things that we've ablated elsewhere. So just temperature control and being a good steward of the patient's skin, because if you, because it doesn't happen very often. I've never seen a penetrating injury with a genicular RFA, but it can happen. It absolutely can happen. So if it makes you feel better, take take precautions against thermal injury.
I'm gonna put all this in the shower, in the wash. You're gonna shower first.
Do you consider motor simulation testing prior to ablation of genicular nerves?
No, never. There's no motor nerves there. I mean, none that make any difference. And so I'll get people that disagree with me there, but I've done, I don't know how many, over 1,000 of these, and I've never seen nor heard of a motor injury.
What are your thoughts on the need for pre-ablation test blocks versus simple intra-articular injection versus moving directly to RFA in a patient with KL4 arthritis?
Yeah, that's a good question. I mean, there's some people that block first and then ablate only if you get 50% or more pain relief with the block. And to me, that makes sense. And I started off doing it that way. Then I noticed the blocks didn't have really any relationship to the success, or enough relationship to the success. It wasn't a lumbar or cervical spine. It wasn't that the injections predicted the success or failure of the RFA. And there's a few credible papers out there that will just say there's not much correlation. So maybe it's selective, but I believe those papers because it corresponds with my clinical experience. And the other component that we've seen in clinical trials where we're required to do a block, we block the knee and the pain goes away effectively. And very commonly, the patient will complain of the pain coming back and being worse than it was. And, I don't think that's the case. There's nothing objectively that has made it worse. But, pain is like a bad car accident. People want to forget it. When it's gone, they just completely forget about it altogether. And then when it comes back, it perceptually seems worse than it was before. So for the reasons that reason, and for the reason that it doesn't appear to correlate with genicular RFA ablation success, I don't block first. I just go straight for the RFA.
What prophylactic antibiotics do you give to patients post-knee replacement that are having an ablation?
Okay, so the prophylactic antibiotics are 1 or 2 grams of Ancef based on weight, combined with 80 to 100 milligrams of gentamicin. That combination, if somebody's allergic to penicillin or one of those 2 drugs, I substitute those for 600 milligrams of clindamycin. If somebody's allergic to any of that, then I will substitute those for 1 to 3 grams of vancomycin based on weight. And that's kind of the whole protocol there.
Is this coded with CPT 64624 and then 64624 times 13 sites?
Yeah, yes, but it doesn't really matter how much you code because you only get paid for the first 2 or 3 sites, and it's diminished to no reimbursement after that. So, this is just done. A little extra work is done on your dime and on your time. But as compared with the 3 ablation zones with the cool RF, it's not very much more. So I would burn typically twice 2 rounds of 2 minutes and 45 seconds with the cool RF. And so this is about the same burn time as that, just slightly more.
What are the common risks, adverse effects in your experience with ablation of genicular nerves one has to be careful about?
Well, not much. I mean, if you know your anatomy, you're not going to ablate the common perineal nerve. You're not going to ablate the tibial nerve or the popliteal artery or anything like that. The critical neurovascular bundle is located in the very back of the knee. The popliteal artery and the tibial nerve, those are critical structures. And if you ablate those, you'll cause vascular injury to the foot and you'll cause motor injury. Same with the common perineal nerve. But as I mentioned previously, we're a good 2.5 centimeters away from both of those structures at any point in time, even at the closest part of it. So, there's a theoretical risk of skin burns. The real risk is post-innervation neuritis. And when doing this, you can get some fairly significant pain of the nerve or any nerve after RFA. And because of that, I typically will inject steroid into the ablation zone. And, the post-innervation neuritis feels a little bit like a sunburn or it can have dysesthesias associated with it. I mean, you could feel, cold, hot, feel like numbness and tingling, you feel like ants crawling on you, just different types of dysesthesia, but most commonly will feel like a burn, like a sunburn. But, I can't remember the last time after having started using steroids with the ablations of the joints. I just haven't had a whole lot, maybe one post-innervation neuritis case in the last 5 years.
Looks like last question. Any thoughts of pulsed RF versus conventional RF? And are you worried about neuritis or neuroma formation after conventional RF thermocoagulation?
Yeah, I'll take the last one first. No, not worried about neuroma. Not worried about neuroma. Not worried about neuroma. The perineurium is not disrupted. And you have to disrupt the perineurium before you get a different growth of pathway of the nerve. And so, even if you do cryo at minus 180, for example, you're still going to get the residual portions of the perineurium still intact. I mean, it will ablate everything. It just ablates at a larger zone. So, if ablated correctly, I mean, you should not get neuromas. You just should not. This is pathophysiologically, that's not what happens. But, pulsed RF is a great technique. I mean, you can do it 42 to 45 degrees C, and you have to ablate for a longer time. Typically pulsed RF for techniques, there's a lot of different techniques. I don't want to digress into that, but instead of a 90-second burn, you'd probably do it for 12 to 13 minutes. And some of our colleagues in Greece do an intra-articular pulsed RF and get really good results out of this, and that's in the range of 12 to 15 minutes. I'm a big fan of pulsed RF. I think it's underutilized. I think it causes less thermal damage. I think it has a greater effect on the depolarization and dysfunction of the nerve. I think it probably has some degree of effect on the dorsal root ganglion, and it has great positive effects, positive attributes on neuropathic pain. Having said that, you don't get paid for it in the US. So, pulse RF is out unless you live in Europe. And I'm not sure about Canada. Dr. Clark would know about that, but it's just not done hardly at all in the United States, even though it's a very good technique, because payers don't like to pay for it, unfortunately.
All right. Well, thank you, Dr. Beall. Does anybody else have any other questions? Oh, there's one question. They missed the IV antibiotic that you mentioned. If you
Sure,
could.
yeah, I can go over that again. So it's 1 or 2 grams of Ancef based on weight, combined with 80 to 100 milligrams of gentamicin, one dose. It's a big dose, but it's just one dose, and it doesn't have a renal adverse effect at that dose given one time. If somebody's allergic to penicillin or one of those medications, I will give them 600 milligrams of clindamycin. If somebody has a problem with clindamycin, I will switch and give them 1 to 3 grams of vancomycin based on weight. So one of those 3 choices. It all depends on the patient's tolerance and their allergy profile.
Okay. One more question.
Yeah.
Theoretically, if the patient responded well to the block, as long as you can ablate the same area with a large volume ablation, shouldn't that be expected to have an equivalently positive effect for the patient? And what is the thinking behind why additional areas need to be ablated on top of what was included in the block?
Well, the first part about that, theoretically, that should be the case. Yes, I don't disagree with the logic there. It just doesn't turn out that that's the case so much. The block is not really that well related to the outcome, and it may be related to the second part of that question. It may be related to the volume, and the placement. If you inject contrast into areas of soft tissue in and around the knee, and inject contrast in the same volume that you're putting injectate, whether it be local anesthetic, lidocaine versus bupivacaine, you'll find it variable. And the deposition of this contrast will sometimes go where you want it to, sometimes it won't. Sometimes you'll find that you put it intravascularly, even though you try to aspirate. Sometimes it runs along the surface of the bone. Sometimes the needle will back up inadvertently and get into some of the deeper musculature. And so it probably has to do with one or all of these factors, maybe some more. But it's just not that predictable. It's not as predictable as we would like it to be.
And what are your thoughts on pulsed RF or peripheral nerve stim if femoral versus ablation genicular in patients with pain post knee replacement? Do the genicular nerves get disrupted after knee surgery?
Yeah, genicular nerves get disrupted and they find new pathways, especially after revision arthroplasty. You know, and some of the arthroplasties are all over the place. I mean, some of them are fairly straightforward, done with a robot and makoplasty or whatever type of robot, which is a cartilage surface removal. Some of them are very large. Some of the tibial trays are, you know, could be up to a centimeter, 2 centimeters, especially in revision arthroplasties. So that's kind of all over the gamut. That's all over the map. And yes, the nerves do get disrupted. Sometimes the anatomic location of these nerves is not where it should be. There's metal where typically bone should be, and it depends on who does it, what brand they use, and how many times they've had a knee replacement. And I've commented on pulsed RF previously, so I'll hit the one about peripheral nerve stim. Peripheral nerve stim, I think, is a great technique. I think it's underutilized probably, but I would never put a permanent stimulator in somebody that has to stimulate it to get pain relief whenever I could do a needle-based outpatient procedure and give them 2 years of pain relief that's good, durable, and provides significant pain function quality of life improvement. So I think, you know, we try to view our practices as minimally invasive fix-it shop, and if people can come in and leave without having an implant, that's what we choose. If they cannot, if they reach the point, maybe pursuant to the discussion about the arthroplasties, maybe they've had a bunch of revision arthroplasties and you have no real targets left over. You know, people like this or people that are refractory to genicular RFA are good patients for peripheral nerve stimulation, and that's a very good technique. I just don't use it as a first line. I use it after genicular RFA.
Can one do pulsed RF of femoral nerve instead?
So no. So the femoral nerve is, you know, that's L2 through L4 is what gives rise to the femoral nerve, and that's the whole quadriceps. So I would probably say that is not a good technique. I mean, if you disrupt that nerve and disrupt that functioning, if that nerve has had a prior injury, you can do, let's say you're doing pulsed RF at 42, 43 degrees C. I mean, that's kind of borderline, right? 45 degrees typically should be neurolytic, could disrupt the function of that nerve. And the femoral nerve is, you know, it's bigger than a kite string. It's a pretty good sized nerve. But if that nerve has been injured or if something has happened to it and it starts to fade at much less temperatures than what really should be neurolytic, and you pulse it at a borderline temperature and you cause an apraxia of that nerve, neuropraxia. I mean, and you won't be able to walk. That's the femoral nerve controls your quadriceps. So I mean, that's a big swing and a miss, and I probably would stay away from that.
Great, thank you. Does anybody else have any other questions for Dr. Beall? No? Okay, well, I would like to thank everyone for joining the call and taking time out of your day. We really appreciate it. And Dr. Beall, thank you for your time as always.
Enjoyed it.
And yeah, everybody have a good evening, good morning, good afternoon, wherever you are. I know you're across the country, and I just want to say thanks again.
See everybody.
Bye.